Hello guys, I'm Dr. Ranjan, your pharmacology faculty at Mero, and I know all of you guys are battered and bruised after the recent INI-CET in the month of November, and it was a difficult paper, guys. So let us see what were the questions in pharmacology part and what did they ask, so that it would be beneficial for the upcoming INI-CET exams, right? So let us begin with the first question, and it's an easy one, guys. Which of the following is not seen with the use of inhaled beta-2 adrenergic agonist like salbutamol, etc.? Hyperkalemia, tremor, palpitation, pulmonary vasodilatation. And it's an easy one, as I said, the answer is hyperkalemia. Right, why hyperkalemia? See, whenever I stimulate beta-2 receptor, it being a GS subtype increases cyclic AMP. All right. Now, if I talk about cyclic AMP, what is the role of cyclic AMP in number one, smooth muscle? Cyclic AMP, smooth muscle, it relaxes. So wherever it is present in the blood vessel, the effect would be vasodilatation. So look at this one effect, pulmonary vasodilatation. Yes, it can be seen. Plus bronchodilation. That is the reason why we use salbutamol-like drug in asthma. Plus uterine relaxation. That is the reason why we use ritodrine-like drug as a tocolytic, right? So cyclic AMP, smooth muscle, relaxes. Whereas if I talk about cardiac muscle as well as skeletal muscle, the effect is an increased contraction or stimulation, you can say. And this is the reason why whenever I stimulate beta-2 receptor by giving drugs like salbutamol or ritodrine, there is palpitation because of cardiac stimulation and tremor because of skeletal muscle stimulation. So palpitation, tremor, they can be seen. Now let us look at what other aspects they have. Whenever I increase cyclic AMP, what it does? Number one, cyclic AMP stimulates a pump present called as sodium-potassium ADPase pump that is present not only in your myocardial cell but also in the cells of skeletal muscle. And this is what is responsible for hypokalemia. So there is hypokalemia and not hyperkalemia, right? And number four, cyclic AMP stimulates glycogenolysis and it stimulates gluconeogenesis. And both would contribute to hyperglycemia. Now, in the recent past, if I look at the PYQs of the last 10 years or 5 years, most of the MCQs were asked on hyperglycemia. The MCQ was, which is not a side effect of a beta-2 agonist, and our answer used to be hypoglycemia because it does not cause hypo but hyper. This time they have asked about potassium, and hyperkalemia is not seen. Rather, what do I see is hypokalemia, and that is the reason why I have to monitor the levels of potassium specifically if I'm using salbutamol or beta-2 agonist, not by inhalational route but by oral or IV route. Inhalational, the risk of hyperkalemia is not that great, right? So this is first MCQ, guys. Now moving on, where multiple options are correct. Now this is where the difficulty level rises too much, right? Which of the following is correct about finrenon? So guys, finrenon, it is a mineralocorticoid antagonist. And have you heard about a drug called as eplerenone? It sounds like finrenon, isn't it? So what have they asked? First option, it causes less hyperkalemia than spironolactone. It has a cardioprotective effect. It gets accumulated in the kidneys. It causes a significant reduction in blood pressure. So we have to find out which of these four options are correct. Before I move ahead, let me tell you about a story about how mineralocorticoid receptor antagonists were developed. Alright, so the story behind the development of mineralocorticoid receptor antagonist, or we call them as the aldosterone antagonists as well. Alright, the first drug that was developed was spironolactone, and we developed it from an androgen. So we took an androgen, modified its structure, and we developed spironolactone. And this drug, being a mineralocorticoid receptor antagonist, it is called as a steroidal mineralocorticoid receptor antagonist because it is androgen derivative. Now, this spironolactone, when it was approved, what it does is it significantly decreases blood pressure. So it can be used in hypertension. I've talked about this. It is a drug of choice for resistant hypertension, or it is a fourth line drug in hypertension. I can also use it in CHF. Chronic CHF decreases mortality, so it has cardioprotective effect. But the problem with this drug was that being an androgen derivative, what it does, whenever I use it for CHF or hypertension, there is a block of androgen receptor and block of progesterone receptor. This gives us side effects like impotence and gynecomastia. Impotence and gynecomastia. So gynecomastia is because of, again, androgen receptor block. Progesterone receptor block can cause menstrual irregularities can be seen. Now, when we had these problems, we thought, okay, how can I get rid of these side effects? So what we did, we took spironolactone and changed the structure and made another drug called as eplerenone, which is more selective for the mineralocorticoid receptor, and it has lesser action on these receptors, and there is a reason why it does not cause, or I can say it causes lesser. So for these disorders today, I should prefer a drug like eplerenone. A drug like eplerenone should be preferred for this, right? Everything was fine up until this. If the patient is poor, I'll go for spironolactone. Patient can afford, I'll go for eplerenone. Now, apart from these two uses, if I focus on hypertension and CHF, block of mineralocorticoid receptor also gives us a good use. So let me write down the drugs again: spironolactone and eplerenone. Now I have these two drugs, and out of these two drugs, any one drug can be used for treatment of diabetes mellitus with CKD. So apart from hypertension, CHF, where I decrease mortality, diabetes mellitus with CKD, if I use these drugs, they decrease the progression of CKD into end-stage renal disease. So these are nephroprotective as well. So here I learned they are cardioprotective, they are nephroprotective as well. Now in trials, when we use these drugs, they're very effective in diabetes mellitus with CKD. But the problem was there was a significant risk of hyperkalemia because of CKD. Already the renal function is declining, there would increase potassium, and mineralocorticoid receptor blockers, they also increase potassium. So hyperkalemia. And because of this, practically these drugs are unusable for treatment of diabetes mellitus with CKD. That is when in 2021, a new drug was approved and we designed it from eplerenone, not eplerenone, so to say. So these are, I can say these are steroidal. We designed something from scratch, which is non-steroidal. It is a synthetic mineralocorticoid receptor antagonist, and that drug is called as finerenone. So finerenone, it is a non-steroidal one, and that is the reason why this drug has even more selectivity for the mineralocorticoid receptor. And now, when I use this drug in diabetes mellitus with CKD, the benefit of this drug is, I'm not saying it does not cause hyperkalemia, but it has a lesser effect on hyperkalemia. Lesser hyperkalemia is seen with this drug. There is a reason why this drug is usable. So in diabetes mellitus with CKD, if I use this drug is not only nephroprotective, this drug also decreases cardiovascular mortality. Why cardiovascular mortality? The reason being, see, try to understand this. In CHF or diabetes mellitus with CKD, in these patients, there is an upregulation of the mineralocorticoid receptor in the kidney as well as the heart. So blocking this effect can give us mortality benefit and prevent nephrotoxicity or nephropathy as well as cardiovascular mortality. Now you would ask me, sir, why is it that finerenone causes lesser hyperkalemia? What is the reason? Now for that you have to understand one basic fact is, where are these drugs concentrated? Now remember, spironolactone, it is concentrated in kidney more than heart, and it is 6 times more in kidney as compared to heart. Eplerenone is concentrated kidney more than heart, and it is 3 times more in kidney as compared to heart, whereas finerenone is concentration in kidney and heart is equal. Right, so it is equally concentrated in kidney and heart. So I can say it is less concentrated in kidney as compared to spironolactone, eplerenone. That is the reason why it causes lesser hyperkalemia, plus it is more selective for the mineralocorticoid receptor, plus if I compare the half-life, if I go from right to left, it has a shorter half-life. And because of shorter half-life plus concentration in the kidney and heart, which is equal, that is the reason why it has lesser risk of hyperkalemia. So I've explained to you about these drugs, how they fare. Now let us go back and see. What about these options? It causes Finrenon. It causes lesser hyperkalemia than spironolactone. Yes, we know that. It has cardioprotective effect. We know that in CHF as well as in diabetes mellitus. It gets accumulated in the kidney, yes, as well as in the heart. Kidney equal to heart. It causes a significant reduction in blood pressure. Now, guys, remember here, spironolactone and eplerenone, they cause significant decrease in BP because of high concentration in the kidney. So if I compare these drugs with respect to, so let me remove this half-life and now compare how much BP can decline. Now all these drugs, they can decrease BP, but the decrease in BP is maximum with spironolactone followed by eplerenone. The decrease in BP is very less with Finrenon. It can never be used for hypertension. I can use spironolactone or eplerenone. Again, the reason is the concentration of the drug. Where is it more, in the kidney or the heart? So here, this option is not correct. It does not cause a significant decrease in blood pressure. So the answer here becomes 1, 2, 3. So where do we have 1, 2, 3? Yes, option A. It was a difficult MCQ. We have to agree to this. Even the examiner, if you'll give this MCQ after 1 month, he himself would not be able to answer this. All right. Moving on to the third question. All right, what is it, guys? In the graph given, drug A is acetylcholine. All right. So what it's saying is drug A is acetylcholine. Fine, right? Identify drug B. What is drug B? Let us see. What is drug B? So first of all, what is A? A is acetylcholine. And this is a graph for the effect. On the y-axis, I have effect. On the x-axis, I have dose. So it's kind of a dose-response curve. Now, what happens to the effect of A? If I add B, the effect increases. So, out of these drugs, to increase the effect of acetylcholine, drug B must be increasing acetylcholine. So, in other words, indirectly, this MCQ is asking which of the following drug increases acetylcholine. Guys, your answer is physostigmine, because it is an inhibitor of ACHE, acetylcholinesterase. Thus, it increases acetylcholine and the effect of acetylcholine. All right. Now, here, if they would have asked you C, what is C? What do you think? What is C? What do you think? What is C? Decreasing effect of acetylcholine. Say drug C. If they would have asked what is C, then your answer would have been atropine. This is something they might ask you in the next exam, giving the same graph, same option. They'll just change one word or one, not even word, I can say one alphabet, right? One alphabet and B to C, and your answer becomes atropine. Which of the following DPP-4 inhibitor requires the dose to be decreased when used concomitantly with ketoconazole? This is a one-liner MCQ picked up directly from the textbook of Goodman and Gilman. You'll find the answer is saxagliptin. There is a line in the section of pharmacokinetics of DPP-4 inhibitors, the saxagliptin. It is a drug that is metabolized by microsomal enzymes. And you know that microsomal enzymes can be induced or inhibited. Ketoconazole is a drug which is an enzyme inhibitor. So what they write is any enzyme inhibitor like ketoconazole, valproate, erythromycin, etc. should never be combined with saxagliptin. I should go for any other drug but not saxagliptin. So it is a direct one-liner MCQ. There is no concept in this per se. Apart from this, the drug that has been frequently asked in both INI-CET and NEET-PG is linagliptin. They'd asked you in renal failure, which is a safe DPP-4 inhibitor in renal failure, and your answer is linagliptin, because it is the only DPP-4 inhibitor that is excreted via liver. L for linagliptin, L for liver. All right. Again, another multiple option correct. Which of the following statements regarding Dronabinol are true? So NAB is from cannabis, so it is a cannabinoid receptor agonist. And I'll come to the options, but before we come to the options, let me teach you a little bit about Dronabinol. How does it act? So let me draw a synapse. Where we have monoamines like serotonin, norepinephrine, dopamine. So these are present in different vesicles. I'm drawing one vesicle so that I can make you understand. And here, let me draw some receptors like the 5-HT3 receptor, 5-HT2 receptor, and D2 receptor, alpha-1 receptor. Now guys, whenever these neurotransmitters are released, like serotonin, dopamine, norepinephrine, they will bind, these ligands will bind to different receptors. 5-HT serotonin will bind to 5-HT2, 5-HT3, norepinephrine will bind to alpha-1. Alright, this much we know from autonomic nervous system. Now let us talk about a receptor called as cannabinoid 1 receptor, that is presynaptic, plus it is GI subtype. Now, I can stimulate this receptor by giving drugs like Dronabinol and Nabilon. So, look at this, it's very simple. The moment I stimulate this presynaptic GI subtype receptor, what it does, it blocks the release of all these neurotransmitters. Fine. If I'm blocking release of all these neurotransmitters, number one, there would be decreased activity on 5-HT3 and D2. And all of you know, a decreased activity on 5-HT3 and D2 will give us anti-emetic effect. So these are anti-emetics. So they are used as, an extra add-on drugs in chemotherapy-induced nausea vomiting when my patient does not respond to the standard antiemetics like ondansetron, aprepitant, etc. Now, whenever I use them as antiemetics, there is one problem. Whenever alpha-1 is not stimulated, these antiemetics, they end up causing hypotension. So for these drugs, I have to monitor the blood pressure. Now, there is another atypical use of these drugs. See, try to understand this, whenever serotonin acts upon 5-HT2, that decreases appetite. Now, if I decrease activity on 5-HT2, this would increase appetite. And that is the reason why it is used for treatment. I can use these drugs for treatment of anorexia in HIV patients. This is an atypical use of these drugs, right? Now, you would have understood about these drugs. Let us go back. All right, look at the options. Option 1, it is used in AIDS-related weight loss. Correct. It acts on cannabinoid 1 receptor. Correct. It is used in chronic pain management. Incorrect. It is excreted unchanged in feces. Now, it's a pharmacokinetic aspect, and this is also incorrect. Right? It is excreted unchanged in feces is just about 5%. 95% is metabolized and then excreted. So here 1 and 2 are correct. So yes, option A is correct. Right, guys. So this is what is Dronabinol, a drug. Its side effect is something that is hypotension plus these other uses. All right. Now, another multiple option correct. Which of the following statements regarding rifampicin are true? Now, option A, it should be taken with fatty mill. That is incorrect. Rather, I should avoid fatty mills with rifampicin because that decreases absorption. So fatty mill, which drugs I take with fatty mill? The drugs I take with fatty mill, these are new drugs in TB like bedaquiline, delamanid, and pretomanid. This is something I've taught you in Mero, guys, that these are 3 drugs, new drugs. One thing common about these drugs is they are to be taken with a fatty mill, right? Not rifampicin. Resistance is due to RPO-B gene mutation. I've taught you this. This is correct. It undergoes enterohepatic circulation. That is also correct. It is pumped out of CNS mainly by P-glycoprotein pumps. That is also correct. We have discussed about PGP in the Mero lectures, specifically in the main videos in detail about the PGP. So, P-glycoprotein pumps, I have told you what are P-glycoprotein pumps. See, suppose this is your blood-brain barrier, and this is a cell of the blood-brain barrier. And whenever I give rifampicin, normally this rifampicin would cross the blood-brain barrier. But what happens on this epithelial cells of the blood-brain barrier, I have these P-glycoprotein pumps which throw this rifampicin back from where it has come, and this is nothing but this is called as efflux. So any drug any drug that is substrate for P-glycoprotein pump can get efflux from the blood-brain barrier. This is what I've taught you already, right? So 2, 3, 4. So where do we have? Option C. 2, 3, 4. These are correct, guys. All right. So it is pumped out of CNS mainly by P-glycoprotein pumps. Is an important aspect of PGP if you have not gone through the videos of main videos. So guys, if you want to crack INI-CET, you must go to the main videos, right? Which of the following drugs acts on VEGF, vascular endothelial growth factor? Now here, in such MCQs, I have taught you how to identify the MABs even if you don't know anything. Now see here, the answer is ramucirumab, and I've told you any drug that acts upon circulation. Circulation means either blood or blood vessel before MAB. See, U is source, that is human, and CIR is for circulation. So if you have C, CI or CIR, it means circulation. And if I look at these maps, LI, pembrolizumab, dostarlimab, Li, so let me write Li here. So if I have Li or limb, it means lymphocytes. So all these drugs, A, B and D, these are immune checkpoint inhibitors. So what they do, they redirect our lymphocytes towards the cancer cells. These are anti-cancer MABs, right? So lymphocytes. So let us talk about some other drugs like VEGF or VEGFR. There is a drug called as bevacizumab. You can see CI, circulation. There is another MAB called as epsiximab. Now this does not act upon the blood vessels. Epsiximab, it acts upon the platelet. So I told you, C or CI or CAR will take you close to the system. And the system is vascular system, either blood or blood vessel or something on the blood. Like for example, there is another drug called as idarucizumab. Now in idarucizumab, this CI stands for circulation again. So it also acts on blood. On what? This drug, I for inhibits, D for dabigatran. So it is an antagonist of dabigatran, again acts on the blood. So any drug that would act upon the blood will have C or CI, right? Similarly, whenever you have N or NE in a MAB, it means it's a drug of neurology. For example, let us talk about a drug called as aducanumab. So aducanumab is a drug which, as you can see, MAB, which is N for neurology. It is a drug for Alzheimer's. For example, let me give you another example here. Erenumab, MAB, it also has N. And I've told you U is source, human, N for neurology. Erenumab is a MAB for prophylaxis of migraine. So any MAB against the brain, it would have N or NE, right? Okay. If a MAB has OS, it is used in osteoporosis. For example, let me tell you about one drug, denosumab. Denosumab, you can look at this drug, MAB, which has OS, osteoporosis. It is a rank ligand inhibitor. Plus, there is a new drug called as romosozumab, and here OS again stands for osteoporosis. It is a sclerostin inhibitor. These are drugs used in osteoporosis. So if I have OS, it means osteoporosis. If I have tox in a MAB, it means some toxin is being targeted. For example, let us talk about a drug called as basilotocumab. So it is a MAB, which, as you can see, it is a MAB which has tox. So it is a MAB against the Clostridium difficile B toxin. And this drug is used as an add-on drug for treatment of pseudomembranous enterocolitis, for which the drug of choice is fidaxomicin. If my patient frequently relapses on fidaxomicin, I can combine basilotocumab. A MAB has BAC, that means it is against a bacteria. Like for example, raxibacumab. So this is a MAB against the bacteria and anthrax bacteria, and it is used for treatment or prophylaxis of inhalational anthrax. If a drug has VI, it stands for MAB as VI, it stands for virus. For example, let us talk about a drug called as palivizumab. Palivizumab, guys, it is a drug, MAB, VI virus. It is against RSV or respiratory syncytial virus, and it is used for RSV. RSV prophylaxis is a MAB. If a drug has TU or TUM, it means it is for tumor. For example, let us talk about a drug called as trastuzumab. So all of you know 2. MAB, which is 2 for tumor. It is used in HER2 positive breast cancer. So guys, this is how you can identify the MABs. At least they will take you nearby to the system on which they act. So here, if you knew this basic concept, even if you didn't know any answer, you could have easily guessed that A, B, and D are against lymphocytes, and C is against circulation or against the blood vessel or the components of blood, right? From that, I could have answered this, ramucirumab. So sometimes, guys, it is not about mugging up things. It is about understanding the basic concept, why the MABs are named as such. All right, another multiple option correct. Which of the following statements regarding rimegepant is true? So it's a partial agonist. Rimegepant is a partial agonist. That is incorrect. Say rimegepant is not a partial agonist. It is a pure antagonist at the CGRP receptor. CGRP receptor is correct, but it is not a partial antagonist. It causes vasoconstriction. No, it does not cause vasoconstriction. Remember, vasoconstriction is caused by drugs like sumatriptan or ergotamine. But these drugs, they do not cause vasoconstriction. It is given by subcutaneous route. Remember, all these gepants like rimegepant, obregepant, etc. All the gepants are oral drugs. They are not subcutaneous. Subcutaneous drugs are drugs like erenumab, eptinezumab, fremanezumab. These are MABs. These are subcutaneous drugs for prophylaxis of migraine. Whereas gepants are oral drugs and subcutaneous route is false. Right? I cannot give it by subcutaneous route. So I can give these MABs by subcutaneous route. I can also give sumatriptan by subcutaneous route. It is only triptan given by subcutaneous route. The last one, obviously, the last one has to be correct. It is used in acute management of migraine. So remember, the MABs are used only for prophylaxis. Gepants, oral route, they are used either for treatment or prophylaxis. Some are approved for treatment, some are approved for prophylaxis, some are approved both for treatment and prophylaxis. Practically, logically, I can use for both, right? There is another drug called as lasmiditan. It is a 5-HT1F agonist. It is an oral drug and it is approved only for treatment. And remember, lasmiditan, unlike the triptan, there is no vasoconstriction here as well. So in your exams, they will ask MCQ on this ditan as well, sooner or later. All right, again, a multiple option correct. A male patient presents with fever, nuchal rigidity, meningitis. CSF analysis reveals low sugar at WBC. Anyways, they've given you directly cryptococcal meningitis. It is, which of the following is used in initial management of this condition? Now, I know some of you guys would have answered one only, right? So that one only is a trap. So I can use flucytosine. Amphotericin B plus flucytosine, it is the treatment of choice. But in some places, if flucytosine is not available, I can replace flucytosine with fluconazole. So fluconazole is an alternative. So remember, what is common is flu. So in treatment of cryptococcal meningitis, the drug of choice is obviously amphotericin B. The second drug can be either flucytosine or fluconazole. The preferred one is obviously flucytosine, and all these drugs are given by one route, that is IV. So 1 and 2 both are correct. Both are correct, right? So here, guys, it's a simple MCQ. A patient on haloperidol therapy develops high-grade fever, severe muscle rigidity, autonomic instability, altered sensorium. CPK is raised. What is the most appropriate next step in management? First of all, the diagnosis. I hope it is not elusive to you guys. It is a case of NMS, neuroleptic malignant syndrome. So, malignant syndrome, it is the only type of extrapyramidal side effect which is fatal in nature. Patient can actually die. So, immediately I have to stop the antipsychotic. And immediately For NMS treatment, I have to give a blocker of RYR, ryanodine receptor, that is dantrolene. Plus, I have to combine a D2 agonist, that is bromocriptine. So the drug of choice is dantrolene, but the most specific drug is bromocriptine. So most specific means opposite of the cause. Why is NMS seen? What is the cause of NMS? NMS is caused because of D2 block. The opposite of D2 block is D2 stimulation. So this reverse mechanism by which I can use a drug is called as most specific. But remember, most specific does not mean the best drug or the drug of choice. No. Most specific means reverse of the cause. So the main drug here, or drug of choice, is dantrolene. Most specific is bromocriptine. I have to save the life of the patient, and that is the reason why I combine dantrolene and bromocriptine. But remember, bromocriptine should not be used in other types of EPS. Why? The reason being stimulation of D2 receptor will worsen psychosis. But then you would ask me, sir, here also it will worsen psychosis. I would answer, yes, it would worsen psychosis, but only if the patient is alive. So here, I have to save the life of the patient first, right? That is the reason why I use dantrolene and bromocriptine. So guys, option A is correct. All right. So I'm never going to continue the drug. I have to stop the drug. I have to save the life of the patient. All right, guys, you can see here, which of the following drug acts on the marked channel in the cardiac membrane? All right, so it's not a difficult MCQ, guys. You can see sodium is moving out and potassium is moving in. Potassium is moving in. So this is a reverse of depolarization, which is done by a pump called as sodium, potassium, ADPase pump. And why ADPase pump? Because ATP is required for this efflux and influx. In other words, the MCQ, the examiner is trying to ask which of the following is a blocker of sodium, potassium, ADPase pump and digoxin. I don't think any one of you would have done this MCQ wrong, even in your sleep, right? Even in your dreams, you could have answered the right answer, right? So guys, digoxin is the answer here. There is nothing much to discuss here. Which of the following drugs is not given in status epilepticus? Levetiracetam, sodium valproate, phosphonatoin. All right. Now remember, out of these drugs, the drug which is never given for status epilepticus is ethosuximide. It is an oral drug. And how would I use it for treatment of status epilepticus? I don't use it. Out of all the drugs, I prefer phosphonatoin. And before that, I also give lorazepam. So lorazepam, I load lorazepam, then I give loading phosphonatoin to the patient. I can use levetiracetam as well. It is an off-label use. In status epilepticus, remember, it is not an FDA-approved use. And whenever I say not an FDA-approved use, it does not mean it is a bad drug. It just means the company has never sought approval from the FDA for this particular use. The company has sought approval for GTCS, partial seizure, myoclonic seizure, but not for status epilepticus. Sodium valproate can be used. Specifically, it is drug of choice for absence status epilepticus. So it can be used. So ethosuximide is the answer. Again, this was not a difficult MCQ. The only use of ethosuximide, all of you know, is for treatment, long-term treatment of absence seizure in children, right? Another multiple option correct. A patient is diagnosed with pulmonary artery hypertension. Which of the following drugs used in this condition acts as a prostacyclin receptor agonist? All right. So let me tell you a little bit about the prostaglandin I2, also known as prostacyclin. And these are vasodilators. They are used in pulmonary artery hypertension. Number one, what have I made here as drugs? Number one, I have made here drugs which is a synthetic prostacyclin or prostaglandin I2, and the drug is called as epoprostenol. Is given by IV route, and it is drug of choice for stage 4 pulmonary artery hypertension. Synthetic one, right? Then we have analogs. So what is the difference between synthetic and analog? Synthetic is exactly same. The structure is same as it is synthesized in my body. And analog is similar, but not exactly same. So here I have drugs like iloprost, Beraprost, Treprostinil. I made analogs. Then what I have made prostaglandin I2 receptor or prostacyclin receptor agonist, and this drug is called as Selexipag. Look at the name of this drug. It has been named smartly. In pharma, ag. Ag means agonist, ant means or an means antagonist. So it is an agonist at prostaglandin I2 receptor, selexipag. Now remember, these two remaining classes of drugs, they're used for treatment of stage 2 and 3 pulmonary artery hypertension, but they are not the drug of choice for stage 2 and 3. The drug of choice in stage 2 and 3 are endothelin receptor antagonists like bosentan, abrasentan. These are the drugs of choice. Anyways, to solve this MCQ, they had asked you, let us go back. What have they asked? Prostacyclin receptor agonist used in pulmonary artery hypertension, epoprostenol, iloprost, ambrisentan, selexipag. Is a simple MCQ, guys. And if you know the nomenclature of drug, agonist, the only one drug which is ag for agonist, selexipag. So even if you didn't know anything, you would have answered this. Answer is what? D, only 4. All right. All right, guys. Next one, single option correct. Patient being treated with MDR-TB presents with bilateral tingling and numbness in both lower limbs, neuropathy below the knees. Which of the following drug is most likely cause? Bedaquiline, levofloxacin, linezolid, clofazimine. Alright, guys. So what do you think is the answer here? Patient being treated for multi-drug resistant tuberculosis presents with bilateral tingling and numbness in both lower limbs. So guys, tingling and numbness in both lower limbs, it tells us about peripheral neuropathy. And look at the options: A, bedaquiline; B, levofloxacin; C, linezolid; D, clofazimine. Now, theoretically here, fluoroquinolones like levofloxacin and linezolid both can cause neuropathy. Now, as I can see here, it is not a multiple option correct type of question, right? I don't know. If it was, then both could have been answered. Now, with a single best response, then I have to find the best possible answer. In MDR-TB, the incidence of neuropathy is higher with drug linezolid. So here, linezolid, it is a better answer. Fluoroquinolones, there is a risk of peripheral neuropathy, but the risk is very less. And there is a reason why linezolid is an answer here. And linezolid, it is an important drug because MDR-TB, the treatment of choice is called as B-PAM nowadays. Bedaquiline, pretomanid, linezolid, moxifloxacin. And out of these drugs, linezolid is an important drug. And I've told you this, how to remember the side effects of linezolid. Remember as bone marrow. So one is B for a bone marrow suppression. And what is predominant is thrombocytopenia or decreased platelets. So we monitor the platelet count here, right? Marrow, from marrow I can remember as MAO inhibition. So because of MAO inhibition, it carries a risk of serotonin syndrome, specifically if combined with any other drug that increases serotonin like a TCA, SSRI, SNRI. Because of MAO inhibition, it increases the risk of cheese reaction as well. Plus marrow for M4, mitochondrial toxicity. See, if mitochondria is not functioning, there would be anaerobic glycolysis that leads to lactic acidosis. If mitochondria is not functioning, your muscles and neurons will not function. There would be myopathy, neuropathy. The MCQ that has been asked here is on neuropathy. Plus, there can be optic neuritis. So these are the side effects which can be seen with your linezolid-like drug, which I can remember as bone marrow. So obviously, if you would have gone for levofloxacin in the exam, it is not a bad answer, right? See, bedaquiline or clofazimine would have been a bad answer, right? Now, the remaining options, bedaquiline, the MCQ they ask you is on QT prolongation is the side effect. Clofazimine, the recent MCQ that asked you is on skin pigmentation. All right, guys, moving on. All right, multiple options correct once again. Which of the following statement about lafutidine is incorrect? And this is the last question we have come down to, guys. See, lafutidine, like cimetidine, ranitidine, etc., it is an H2 blocker which can be used in peptic ulcer disease or GERD and Zollinger-Ellison syndrome. Now, whenever I block H2 receptor, they decrease hydrochloric acid, and we know that this is the primary or the main mechanism of H2 blockers. But this particular H2 blocker has a different action. It does not decrease, rather it increases nitric oxide in the stomach. And this increase in nitric oxide, what it does, it causes vasodilatation, and it increases the gastric mucosal blood flow. That also increases mucin and bicarbonate production. So gastroprotective effect increases. Plus, it also increases somatostatin release, and all of you know, if I increase somatostatin, that would decrease gastrin and that would decrease SCL. This is another way of producing gastroprotective effect. So lafotidine is an H2 blocker that is not that commonly used, because all of you know we have moved on from the H2 blockers to the better drugs, that is PPI or proton pump inhibitors. And this is where lafotidine, the options that are correct are 1, 2 and 4, and yes, we have option D as 1, 2 and 4. Now remember, here in the coming exams they're going to ask you about a drug called as vonoprazan. Vonoprazan is a PCAB or potassium competitive acid blocker. Now, how is vonoprazan different from PPIs is what they're going to ask you. PPIs are irreversible inhibitor. PCAB is a number 1 reversible inhibitor. Number 2, PPIs decrease only food-induced acid secretion. This drug, it decreases both food-induced as well as basal acid, both can be decreased. PPIs have to be taken 30 minutes before food. They can be taken with food, without food, whenever you want, you can take them. As of now, vonoprazan is approved only for treatment of H. pylori along with antibiotics like amoxicillin, clarithromycin, etc. So kit is available where you can use it. So mind it, this is what they're going to ask you. And if they would have asked an MCQ on vonoprazan, that is the future, I would have been more happy rather than asking MCQ about lafotidine, which is past. So some professor who has asked this MCQ is more interested in the history of peptic ulcer disease, lafotidine-like drugs. They have asked it, and if you could not solve this MCQ, it is okay. Such MCQs are not rank deciding MCQs, and what makes this MCQ even more difficult is multiple options are correct. With that, guys, we have come to the end of this session, and as you can see here, more than 50% MCQs were in the zone of difficult MCQs, and that is how INI-CET has been from the past many years. It has been conducted. So be it AIIMS, JIPMA, PGI, they are known for making tricky MCQs. That is the reason why INI-CET is a difficult ball game altogether. Now, I'll tell you those students one fine point of advice. Those who have not done well in INI-CET, it does not mean you will not do well in NEET PG. NEET PG again is a different ball game altogether, right? INI-CET, the PYTs are slightly weird and different from the NEET PG. NEET PG is more accessible because there is single best option. MCQs are asked in NEET PG. So I have seen students who have not done well in INI-CET getting a very good rank, even under 1000 in the NEET PG. So if you have been dissatisfied by your result, even if you have not qualified in INI-CET, nothing is lost yet. You can still work hard and easily come under 1000 in the next NEET PG or even in the INI-CET. Right, guys? So all the best to all of you. Whoever has got good ranks, my congratulations. Who have not, there is still some way to cover. And always believe in yourself, have faith in your abilities that you can do it. And probably you will do it. Take care. Bye-bye. This is Dr. Ranjan.